Kashina, a graduate, 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse in various hospitals, long-term care facilities, nursing homes, with patients in their private homes. From doing clinical rotations here in the United States, from 2 graduate medical education programs, Healthfair Internal Medicine Residency Program, Detroit, Michigan, and Preventive Family Medicine Residency Program, Springfield, Illinois, from various observerships and externships from St. Elizabeth Family Medicine Residency Program, Chicago, Illinois, working with Dr. Saida Zahidi, a program director emeritus, certified in family medicine and pediatrics, and from Huntsville Family Medicine Residency Program, Huntsville, Alabama, working with Dr. Mary Cristani, the program director in family medicine training service, and also from Harris Fort Worth Methodist Hospital, Fort Worth, Texas, working with Dr. Fidelis in an internist in internal medicine, and a master's in business administration from Davenport University, Grand Rapids, Michigan, and some research experience from the University of Texas Southwestern Psychiatry Department, working with Dr. Carol North and Dina Downs, and my graduate medical education experience from the 2 programs. I was also privileged to work with the program directors at Healthfair Internal Medicine Residency Program. I worked with Dr. Kimberly Baker Jamal, an internist in family medicine training service, and also Dr. Alvin Bowles, a pulmonologist in pulmonary medicine and critical care medicine. And at Springfield Family Medicine Residency Program, Springfield, Illinois, I was also privileged to work with Dr. Janet Albers, the program director in inpatient, outpatient, and obstetric settings. And I'm currently involved in preventive care and education, utilizing my Cisco Webex and my Ustream channels, and also applying for residency, and also involved in preventive care at various community churches, at charity works, and also to various individuals. And I try to talk about the health topic every day. We learn by reading, by talking about health topics. And this show was actually designed to create a forum for healthcare professionals, and also not healthcare professionals, to discuss some trending health topics that we see every day in our communities, in our clinics, in our hospitals, and to learn about them, what causes them, what are the signs and symptoms, how common is it, what are the treatment modalities, how do we prevent it, and ultimately to be able to utilize that knowledge to be able to create a healthy community. Today our topic of the day is urinary tract infection. We're supposed to talk about that yesterday, but I had some emergencies that I had to take care of, but I still shared it on my Facebook wall, and I encouraged everybody to check it out and take a shot at the Powerball question. So today we'll talk about acute cystitis or urinary tract infection. The name actually is derived from the definition, which I'm going to talk about. What is it? Well, it's an infection that affects the urinary tract infection. So that's the urinary tract. So that's why it's called a urinary tract infection, because it affects the urinary tract. And then it's also called acute cystitis because the bladder is also known as if you see anything that has cystitis, then that actually has to do with the bladder. So an infection of the bladder, which is also part of the urinary tract, is acute cystitis. Other parts of the urinary tract includes the bladder, the kidneys, and then also the glomerulus. All the other parts of the kidneys are parts of the urinary tract. But then acute cystitis or urinary tract infection is an infection that affects the lower part of the urinary tract, which is quite different from an infection that affects the kidney, which is called acute pyelonephritis, and which is actually more severe. So how common is it? What's the epidemiology? Well, it actually accounts for 6,000 visits to the clinic every year. So it's actually pretty common. 6,000, that's a huge number. So it's pretty common. We see it in our clinics every day. So what causes it? Well, in 80 to 90% of cases, it's caused by E. coli, which is a bacteria, a gram-negative bacteria. So that's the cause in 80 to 90%, which is a tremendous number, which is a major part of the causes. And then in 20 to 30% is caused by other bacteria, which includes saprophyticals and Proteus mirabilis and other types of bacteria. But then the major cause is actually E. coli, which is a gram-negative bacteria. So going down to the symptoms, actually, let's talk about the risk factors. Why do people get it? Well, if you're female, if you're sexually active, then you're at risk of getting it. If you're a young boy, because of the structure of the urinary tract in boys, they're also more susceptible to getting a urinary tract infection. And then also, if you have a folic catheter in, then also you're also at risk of getting a urinary tract infection. So those are the risk factors. And then also in terms of the symptoms, what symptoms do you experience? Well, most people experience burning or urination. Most people experience frequency, which is actually going to the restroom too many times. And then also sometimes experience burning or urination. And also they also experience suprapubic tenderness. Or suprapubic pain, that is pain in the lower part of your abdomen or right above your genital area. And then they also experience nausea and vomiting, especially when the bacteria has entered into the bloodstream. Sometimes they also experience a fever, and then also sometimes they also experience high pulse. That's tachycardia, and that's when the bacteria has also entered the bloodstream. So these are some of the symptoms that people experience in a urinary tract infection. Then what are the signs? By signs I mean the physical examinations, the things that can be measured, that can be able to give you an accurate diagnosis. Well, the signs include, like we mentioned earlier, tachycardia, a fever, suprapubic tenderness, that can be elicited on palpation. So if you palpate the patient's abdomen, or if the physician or the healthcare provider palpates the patient's abdomen, and they are able to elicit suprapubic tenderness, then that means that the person will actually have a urinary tract infection. And then fever, which is anything above 99. Above 99 degrees is actually a fever. And also if they have tachycardia, then that's also a sign of urinary tract infection. And then also in terms of diagnosis, how is it diagnosed? Well, most times it's actually diagnosed based on the symptoms, which includes if you're at risk of getting a urinary tract infection, and you have all the symptoms that we talked about, which is the burning or urination, the frequency, the suprapubic tenderness, and fever, nausea, and vomiting, and you present to the physician, they can be able to treat you just based on these symptoms, without doing any other test. But it's diagnosed by urinalysis, which is just a test that a test is to check for your urine, to check for the presence of any bacteria in your urine, and then also by a urine microscopic analysis to look at the components of your urine and also a urine culture. Urine culture is not mandatory, just based on the urinalysis. It can be treated just based on the urinalysis. The urine culture most of the time is done to be able to check for the particular bacteria that is causing the problem, and also it's done most times if there's any complications, if it's a complicated urinary tract infection, which is if you're diabetic, if you're pregnant, and if you've had an infection so many times, then it's considered a complicated urinary tract infection, and then that's when you need to have a urine culture. And then on urinalysis, if you have more than 100 white blood cells on urinalysis, if you have positive leukocyte estimates, if you have positive nitrates, then that's actually considered positive. And the leukocyte estimates is actually pathognomic of urinary tract infection, because it's actually due to the increase in the white blood cells. And then also if you have nitrates in the urine, which is actually because of the presence of a gram-negative bacteria like E. coli, that's almost pathognomic of E. coli infection. But then urine culture is still the confirming test to be able to determine what exactly the causative bacteria is. So in terms of treatment, how do we treat it? Well, the treatment is actually pretty the same. I mean, there hasn't been any set changes in the treatment, but it's normally trimethoprim, sulfamethoxazole, or Bactrim, which most people might actually know. So it's Bactrim, and you give the patient Bactrim double strength for 3 days if it's an uncomplicated infection, and if it's complicated, then it's for 7 days. And then if the patient is pregnant, they can take Bactrim, because Bactrim is actually toxic. It causes lots of toxicity to the baby. So they have to take something else, which is amoxicillin, and either amoxicillin or nitrofurantoin. And nitrofurantoin is given 100 milligram 3 times to 4 times a day for 5 days. And then for amoxicillin, that's also given for 7 days. And if they have diabetes, which actually is a complicated infection, then they have to also take antibiotics for 7 days. And then if you're pregnant, you have to have a repeat culture done in a couple of weeks to check for eradication of the bacteria. There are also lots of other medications that can be given, which includes Keflex, which includes ciprofloxacin. So the options of antibiotic therapy is actually quite numerous, but the standard is actually Bactrim double strength twice a day for 3 days. And then if you're pregnant, amoxicillin is a good choice, and also nitrofurantoin, so 100 milligram 3 times to 4 times a day.